Whenever I hear about a new surgical procedure, I often wonder, what would it be like to be the first person to perform a procedure that nobody else had ever done before? Well, today we're going to be talking with Dr. Marguerite McDonald. Dr. McDonald was one of the first people in North America to perform a number of different laser vision correction surgeries. And today we're going to be talking with her about that subject as well as many others. Dr. McDonald?
I want to talk to you.
Not now, later.
No, now.
Hello and welcome to OCuTALK. Today we'll be talking with Dr. Marguerite McDonald, who is a clinical professor of ophthalmology at both NYU and Tulane and a cornea and cataract refractive specialist at OCLevision in Long Island. Dr. McDonald, thank you for being with us today.
My pleasure, thank you.
Dr. McDonald, I thought we'd take a second here just for you to introduce yourself and tell us a little bit about you.
Well, as you mentioned, I do cornea, cataract, and refractive surgery. I was born in Chicago. I went to medical school at Columbia in New York City, stayed there for an internship in internal medicine at Lenox Hill. Then I did the Cornell Manhattan Eye Near residency program and a cornea fellowship in New Orleans, Louisiana, where I stayed and joined the faculty. And I stayed there for a long time till Hurricane Katrina washed much of the city away, and I relocated to New York, to Long Island with my husband.
Very cool. Well, Dr. McDonald, I happen to know that you performed the world's first laser vision correction procedure in Louisiana back in 1988. Can you tell us a little bit about how laser surgery has changed in the past 30 years?
Oh yes, it has changed a great deal. So at the birth of laser vision correction, we had no idea of the potential. We had no idea how it would change the way medicine is practiced, really. So we started shooting at little plastic discs with our very primitive laser, and then we started cadaver animal tissue, then cadaver human eyes, then living rabbits, living monkeys, and we went through many, many thousands of treatments. And finally, we were able to start with living sighted humans in March of 1988. So the original surgery was PRK, which is still done today, otherwise known as surface ablation. There's no cutting. The surface is gently prepared with a Q-tip. The laser is fired at the surface with a very precise algorithm that removes just the right amount of tissue to correct the person's nearsightedness, farsightedness, or astigmatism. And then the patient wears a bandaged contact lens for a few days. They're quite comfortable with the modern medicines that we have now, and vision returns very quickly, usually within within the first week, 3, 4, or 5 days. Then along came Lasik. So Lasik involves a second device that creates a flap. And then the original excimer laser is used to remove tissue as in PRK. And then along came the SMILE procedure and intracorneal inlays, which are bits of synthetic polymer that are placed inside the cornea. So we have many options now, but the original PRK is still performed and is very popular. It's just that each patient is a different case, and the surgeon has many options now and will recommend the option that's best for that particular patient. So it's a good time to pursue refractive surgery.
Can you talk a little bit about what makes the difference between what refractive method you use?
Sure. I should also mention, by the way, that in the beginning, we did not have trackers. Now we have high-speed trackers, so the patient doesn't have to worry if they look around a little bit during the case. Each shot will still fire and go into position with submicron accuracy. And that's actually an adaptation of NASA technology. So we make the decision based on certain things. The thickness of the patient's cornea has a great deal to do with it. The curvature does have something to do with it. The exact prescription has something to do with it. So refractive surgeons are knowledgeable in all these things and can guide a patient to the right choice.
Very good. So in what ways has the increase in laser vision correction impacted cases of dry eye?
Well, first, many patients with dry eye are pursuing laser vision correction because they can't wear their contacts anymore. Their eyes are too dry. So, an incredibly high percentage of people coming for a pre-op exam are found to have dry eye that must be treated. Often we treat it and they say, hey, this is great. I want to stay in my contacts, which is fine. But at the very least, we have to detect it and pre-treat it so that the pre-op measurements will be accurate and the patient will sail through the post-op period easily and quickly and be seeing very well and be back at work. So we do our pre-op evaluation, we pre-treat, and then we continue treatment afterwards. So now I would say there is such an appreciation of dry eye in the perioperative period and so many wonderful options for us now to treat it that it's not the issue it may have been 20, 25 years ago.
What are some of the things that you use to treat dry eye before people are coming in for these surgeries?
So there is an internationally accepted treatment ladder where starting with what you do for very mild dry eye, and there are wonderful diagnostic tests now that can help us determine the exact level of dryness. So at each stage, there are different recommendations, and this is all based on the scientific literature, and it's well accepted around the world. So a very mild dry eye would get artificial tears. A more severe dry eye would get preservative-free tears. And one of the prescription medicines, perhaps, that are available now, there are 3 that are available for moderate to severe dry eye. About 86 to 92%, depending on the papers you read, 86 to 92% of the dry eye patients have an associated condition called blepharitis, which is chronic rosacea of the eyelids. So if you pretend that my arm is your eyelid, right at the edge of the eyelid, right where the lashes dive into the top of the eyelid wall, there are clumps of a dandruff-like material and plugged oil glands. And all of that debris, which has actually been associated as the cause of dry eye, that must be cleared away twice a day. And I ask my patients to do hot soaks and scrubs using OCuSOFT lid scrubs. They're available over the counter in every drugstore in the United States and in many around the world. So that clears the debris away. That really goes to the etiology, the cause of dry eye. And as we go up the treatment ladder, sometimes we add nighttime ointments. If they have pure dry eye, moderate to severe, we ask them to use Retain MGD PM ointment, the nighttime ointment. If they have significant blepharitis, in addition to the dryness, it's a prescription ointment like erythromycin or bacitracin ophthalmic ointment. And, if they have much more severe dry eye than that, they might need an in-office treatment. And we do have several in-office treatments that can clear up the lids and treat the dry eye and blepharitis very quickly.
Very good. Well, I think one of the things that is top of mind for everybody right now is what's going on with COVID-19. Can you talk a little bit about how COVID has affected your practice?
Oh, yes. COVID hit New York State very, very hard. In the very beginning, our large practice, it's in 4 states. We have many dozens of offices. We closed everything except for regional emergency centers, 1 in each area, that were dealing with vision-threatening emergencies only. So most of the doctors were furloughed. Most of the staff was furloughed, the technicians, the scribes, the front desk people. So it was virtually a complete shutdown. About 6 weeks ago, we started to come back very slowly. We weren't sure what the demand would be. Some people were dying to get in. Some people are still afraid to come in. They're so terrified of catching the virus. So as we slowly rolled out our welcome mat again, we put in very strict measures so that people would feel safe. Everybody gets their temperature taken. Everybody must wear a mask in our office. We removed most of the chairs in the waiting room, so only a tiny handful of people can be in the office at one time. we don't move people around. We try to keep them in one room that's been cleaned for them. They see us scrub down the whole room with gloves on and with powerful antiseptics and anticidals, and they know it's clean. We have plexiglass shields everywhere, separating the people from the front desk. And we often have people wait a little bit in the car and call them in if we see that we're starting to get one or two too many people in the lobby. So it's been very carefully addressed, and patients who come see us feel comfortable. And I have to say, my colleagues across the United States and around the world are all doing the same thing.
Right. What advice would you give to somebody right now that's suffering from dry eye? Is now a good time to come in the office? Is that what we're recommending people to come in and go ahead and take the necessary steps, obviously, but is it a good idea to go ahead and come in and get these things addressed?
Absolutely. It's a good time to come in because of all the precautions I just told you about, but also everybody's working from home, or I should say a large proportion. They have hours and hours sitting in front of their digital devices. So whenever you're in front of a digital device, the normal blink rate of 20 times a minute drops to 3. So we have an epidemic of dry eye caused by COVID and all the people working at home. So we ask them to come in, but if they're really terrified, if they're in a high-risk group, they can do telemedicine with us. We've been doing telemedicine for months now. Actually, dry eye is a fairly easy thing to diagnose and treat with telemedicine. But cameras now are so good in laptops and iPhones. People can get their phone up close to their eye and I get an excellent picture. So I would encourage people to come in, but if they're really fearful, we can do telemedicine while they're in the safety of their home.
Dr. McDonald, one of the things we've talked about on this channel a couple times is a lot of times people deal with dry eye and they think that it's an inconvenience, but hey, my eyes are dry, it's not that big of a deal, right? But there are some negative health effects that can come from prolonged dry eye sufferers. Can you talk a little bit about that?
Sure. I'm the director of our Dry Eye Center of Excellence. I really have a very high percentage of my practice with dry eye. So I tell people very few of you will go blind from dry eye. Some will, less than 0.1%. And when they do go blind from dry eye, they find someone like me. I've had people with such severe dry eye, their eye perforates and the contents of their eye extrudes. Very rare. But when you have that severe dry eye, you find someone like me to deal with it. So you get an emergency transplant in the middle of the night. The vast majority of people will never get that bad. But the vast majority of people will eventually, if you don't treat the dry eye, it's a downward spiral and it will become a real quality of life issue. You start to get red eyes, you have light sensitivity. It's difficult to drive when the lighting isn't just right. You can't sit in most restaurants because of the lighting, or if you go into a restaurant, you have to ask for a special table so you don't get too much light. Also with blepharitis, which almost all the dry eye patients have, you get red, bleary, smeary looking eyes. Everybody thinks you've been crying or drinking or both. You get styes and a cousin of the stye called a chalazion. You lose all your eyelashes, which men don't care that much about, but even women are frantic when this happens. But even men look weird without eyelashes, and eyelashes serve to keep debris out of your eyes too. They serve a purpose. So in extreme cases, as you march toward the very tiny percentage that could go blind, you get blood vessels growing in where they don't belong. You get an alteration of the optics of the eye. It becomes a quality of life issue for almost everyone with dry eye who doesn't get it treated.
Well, and obviously, I know that this is a very intimate subject for you. To our viewers at home, when should I be concerned? When should I consider that this is a problem versus just an inconvenience for a particular day?
So if you have any of the following symptoms, fluctuating vision. A lot of people don't realize that fluctuating vision is almost always dry eye. Cataracts don't change moment to moment. Macular degeneration doesn't change moment to moment. Dry eye does. So fluctuating vision, mild itching, light sensitivity, redness, stinging and burning, are associated with dry eye, especially those, the majority that also have blepharitis. So those are some of the symptoms. But the other thing is, if you use artificial tears on any kind of a regular basis, and I mean once a day, once a week, if you have a pattern, even if it's that occasional, if you have a pattern and it makes your eyes feel better to do that, you should pursue an eye exam with an MD or an OD. So if you take the occasional artificial tear because you were on the front of a speeding motorboat on the 4th of July and you sat at the front of the boat without the windshield, of course you're going to need artificial tears. If there's some extraordinary circumstance that dries your eyes out like that. But if otherwise you seem to need a drop on a regular basis, that's a red flag. You should see your eye doctor.
I don't think everybody realized that that's not something that you have to deal with. I know you are very knowledgeable about the fact there are lots of things you can do that, as you said, varying from moderate to severe cases. Some things are easy to do, some things are maybe a little bit more invasive. But the point of the matter is, you don't have to live with this problem unnecessarily.
This is true. Often with a modest treatment regimen, we get people back into contact lenses who dropped out of contacts 20 years ago. And now they want to wear them to go to their son's wedding, and they want to take their glasses off. They come to us, we give them a modest regimen, and they're back in contacts. And of course, as I mentioned, preparing people for laser vision correction or cataract surgery, it's critical to treat the dry eye.
Very good. Well, Dr. McDonald, thank you so much for joining us today. I appreciate you taking the time and visiting with us, and hopefully we'll get to speak to you again real soon.
Thank you, Tom. My pleasure.
All right.
Have a good evening.